Okay. Sige. Let us continue, everyone, about our anti-asthma drugs. So we are done already with the sympathomimetics. And then we are in the methylxanthines already. Let's talk about the effect of methylxanthines in the body. So this is not just about theophylline and aminophylline class, ha? We will talk about the methylxanthines in general. So this includes the effect of caffeine and even theobromine inside our body. So this is not just about asthma. Now, you are going to take methylxanthines class in the CNS, even at low or moderate dose, well, especially caffeine. This will cause arousal of our central nervous system, and that means there is increased alertness, and yun, hindi ka makakatulog. So definitely, methylxanthines are considered CNS stimulant. However, our problem with methylxanthines, especially caffeine, is it can cause tolerance. Okay? Tolerance, meaning as you take caffeine every now and then, your body, your receptors are no longer will become insensitive to caffeine. So kahit uminom ka pa ng kape, hindi ka na ma-alert. I mean, hindi ka na na-alert, meaning makakatulog ka pa rin. Okay? So yan yung mga persons na nagrereklamo na hindi na sila walay talab ang coffee sa ilaha if mo inom sila. So that's number one, ha. If you say methylxanthines, especially caffeine, CNS stimulant talaga yan. Pero there is this so-called tolerance. So if you have become tolerant to caffeine, para magkaroon yan siya ng effect again in your body, kung gusto mo hindi ka makakatulog kaagad, you have to increase the dose. Okay? You have to increase the dose. So hindi na siya yung usual dose na tinitake mo para to keep you awake. However, our problem here is that hindi lang naman sa CNS magkakaroon ng effect yung ating methylxanthines. So meron din naman sa cardiovascular. Now, please take note, sa CV, it can cause palpitation. We know that very well. So it's not just caffeine, ha. This is true to all other methylxanthines. Pero what will happen to the heart? There will be increased chronotropic and inotropic activities, meaning there will be increased heart rate and at the same time, force of contraction. And actually, for sensitive na mga tao, the palpitation will really go into arrhythmia. And that is, that life-threatening. Okay? So, hindi talaga siya pwede na mag-i-increase talaga ng dose na grabeng-grabe, no? Kung wala na kanatablan sa kape, you have to look for other things or activities to keep you awake if you want to be awake. Okay? Kasi again, magkaka-develop ka ng tolerance. So you drink coffee class in moderation. Wag naman 3 times a day. Especially if you are fond of drinking coffee na maraming asukal. Yung mga 3-in-1 natin contains a lot of sugar. And instead of decreasing the viscosity of your blood, because that's the effect of methylxanthines, baliktad yung mangyayari. Because of the presence of a lot of sugar, hindi na mai-improve yung blood flow mo. Instead, you will be at risk of having hyperglycemia that may lead to diabetes mellitus. So please be careful with the dose of the coffee that you are taking, especially that type of coffee which contains a lot of sugar, like the 3-in-1. So it's better to brew your own coffee, pero again, at moderation, just to keep you awake, but at the same time, keeping away from the cardiovascular activity. Okay? Now, there is one methylxanthine derivative that is used for intermittent claudication. We are actually done with our discussion with the pentoxifylline last time. But please remember, this is a drug used for intermittent claudication. You can still remember what intermittent claudication is. Remember, it's the blood clot or yung atherosclerotic plaque deposits in the blood vessel in the periphery, especially sa mga paa natin. And that will obstruct blood flow sa ating legs. And since there is no enough oxygen in that part of the body, the patient may experience severe pain in his or her legs, na kahit konting lakad lang, hindi na niya kaya. So, again, pentoxifylline is a dimethylxanthine that can improve blood flow. It can decrease blood viscosity. Since remember, there is an obstruction. Okay, this is just to aid the blood flow. Pero again, the decreasing blood viscosity activity is true to all methylxanthine. Okay? Yeah, Abelianosa is present. Okay, gastrointestinal tract. How about the GI tract? If you are going to consume methylxanthines class, especially coffee, it can lead to the secretion of our gastric juice and other digestive enzymes. So this is the reason why if you're going to drink coffee or tea, you really have to eat. Okay, you really have to eat because again, this can increase the secretion of our gastric juice, and if you don't eat, you may experience hyperacidity. Okay? And then again, digestive enzymes included dyan sa mare-release. Now, ano pa ang mangyayari sa inyo? Yun na, kailangan niyo siyang kumain talaga. Meron kasi mga tao na kapag ka-morning, nagkakape lang sila. Wala silang, kinakain talaga na iba. So, ano yung ida-digest ng inyong enzymes? Saan nyo gagamitin yung inyong gastric juice kung walang like solid food? Iba kasi yung digestion process natin sa ating liquid food. Yung mostly sa ating liquid food, diretso na kasi siya. Like from the stomach, diretso na siya sa intestines. Okay? So, walang paggagamitan yung ating gastric juice. Yan yung magli-lead sa hyperacidity. And in some cases, you may experience GERD or gastroesophageal reflux disease or even ulcer at worst. Okay? So, please again, eat if we are going to consume methylxanthines. And at the same time, methylxanthines are weak diuretics, okay? Especially theophylline, but caffeine can be a diuretic also, but take note that the diuretic effect of caffeine is not really sufficient for it to become a diuretic agent. But I don't know with you kasi I'm not really into drinking coffee. I don't drink coffee. I do not appreciate the lasa of the coffee talaga kahit anong kape pa yan. Pero I don't know if you have observed that if you drink coffee, talagang parati kang umiihi. Okay? There will be increased urine and urination for you. So kasi again, talagang weak diuretics yung ating mga methylxanthine. Okay? Now for the smooth muscles, ito yung effect of the methylxanthines that we need for asthma. Kasi sa smooth muscle, caffeine and other methylxanthines, especially theophylline, can relax the smooth muscles, especially the bronchiole. So it can cause bronchodilation. And if there is bronchodilation, there is increased airway. So para makaginhawa ang atoang patient. And what is good here is it does not develop tolerance. Okay? Yung tolerance na sinasabi ko kanina, it's on the CNS ha. CNS niyan na effect. It can cause tolerance. So, mababawasan yung pag-increase ng iyong stimulation of the CNS. Pero kapag ka sa bronchodilation, kahit gamitin mo siya always, si theophylline for asthma, it does not develop tolerance. Kaya niya pa rin i-relax yung smooth muscle. But remember, since meron pang activity si methylxanthine sa other parts of the body, this will limit the dose. So, kasi hindi nga natin gusto yung especially cardiovascular activity of the methylxanthines. Okay? And at the same time, our methylxanthines can inhibit antigen-induced histamine release. So this one is still good for asthma though. Just remember, histamine is included in the pathophysiology. If the mast cell gets degranulated, including in the granules na nare-release is yung histamine. And histamine can also cause bronchoconstriction. So if the methylxanthine can inhibit that, so talagang siya, very important for asthma. Okay? So how about for the skeletal muscles? Sa skeletal muscles naman, methylxanthine can strengthen the contraction of isolated skeletal muscles, meaning it can improve contractility and magre-reverse siya ng fatigue sa diaphragm ng patients, especially the COPD. Remember when we breathe class, kailangan natin yung work ng diaphragm. So diaphragm is like a muscle. And caffeine and other methylxanthine can improve contractility of that muscle. And that can aid our patients sa paghinga. Especially kapag COPD patient siya. So, ang clinical use ng methylxanthines talaga, especially the theophylline, talaga siya, effective bronchodilator among our methylxanthines. Okay? But if you just want to stay awake, be awake, you want to be alert, you consume coffee kasi nga because of the caffeine. Actually, tea contains caffeine also, but it does contain theophylline. And then chocolate also, the theobromine can keep you alert. However, please do not consume chocolate na milk chocolate kasi milk can defeat the activity of the theobromine in the CNS. So remember, milk contains a lot of tryptophan, and tryptophan inside the body may become melatonin. That is our hormone of darkness. We call that hormone of darkness si melatonin. And melatonin has something to do with our circadian rhythm and yung sleep natin. So that is the thing that will explain bakit pag nagko-consume tayo ng milk, nakakatulog tayo. Okay, release of melatonin. Melatonin is different from melanin, ha? Melanin is our pigment sa skin. Melatonin is a hormone. We call that hormone of darkness. Where does it come from? It comes from tryptophan. And then tryptophan in the brain will be converted into melatonin. So, nag-i-induce yan siya ng sleep, and responsible yan siya sa circadian rhythm. It is called the hormone of darkness because it's released during nighttime. So talagang typically and yung normal talaga sa gabi tayo natutulog. Okay, do you have questions or clarifications? Wala? Okay lang. Okay? Sige. So, what are the things you need to know about theophylline? It has a narrow therapeutic index. So, what does it mean? Ano nga meaning pag ang drug may narrow therapeutic index? Can you still remember? Anong ibig sabihin yan? Ganito ha, pag the drug has narrow therapeutic index, if we have the graph here, and this is the effective dose. Ayan, effective dose siya. Ito yung kanyang toxic dose. Okay. So, ayan. Meaning niyan, yung difference between the effective dose and the toxic dose is very little. And this will mean that the drug is considered toxic. Kasi konting increase mo lang sa dose, na-achieve mo na ang toxic dose niya. So, you may experience signs and symptoms of toxicity. Okay? So, yan yung ibig sabihin, class, ng narrow therapeutic index. So, one example of the drug with a narrow therapeutic index is theophylline. Okay? We use this for asthma, but for example, the patient forgets na uminom na siya, tapos uminom siya ulit, so nag-double dose siya, pwede niya nang ma-achieve yung toxic dose and pwede niya nang ma-experience yung signs and symptoms of toxicity. So, ano ba signs and symptoms of toxicity ng theophylline? The most life-threatening one is, syempre, arrhythmia. Kasi di ba, yun yung iniiwasan natin na effect ng methylxanthine. Okay? So, if we compare that with a drug na may broad therapeutic index. So, example, paracetamol. Yung effective dose ng paracetamol, we know that 1,500 milligrams. Okay, yan yung dose natin sa market. Tapos, yung toxic dose naman ni paracetamol is 3,000 pa. 3,000 milligrams. So, medyo malayo. Kahit naka-double dose ka, like you forget, hindi ko sinasabing mag-double dose kayo ha. Accidentally lang, nag-double dose kayo, hindi niyo agad-agad na-achieve yung toxic dose. Okay? So, 3,000, malayo pa kasi siya, 3,000 milligrams. And that means paracetamol is considered a safe drug. Si theophylline, including digoxin, phenytoin, all of them are considered toxic drug because they have narrow therapeutic index. So for theophylline class, the effective dose is 3 to 4 milligrams per kilogram every 6 hours. Now, if we look at the plasma concentration, again, the effective dose is between 5 to 20 milligrams per liter. That's the effective plasma concentration, ha? But, effective dose pa niya ito, ha? Nasa 20 pa, pero at 15 milligrams per liter, the patient may experience signs and symptoms of toxicity already. So, pwede siyang mag-anorexia, nausea and vomiting, abdominal discomfort, headache, and anxiety. Okay? So, paano kung nag-double dose ka? Na-achieve mo yung 40 milligrams per liter na plasma concentration. Ayan na yung seizure and at the same time, the life-threatening arrhythmia. So, masyadong malapit yung effective concentration to that of the toxic concentration. Okay? Do you have questions or clarifications? Wala? Sure ha? Sige. Ano difference ng antitussive and expectorant? Ganito. If if a patient na may cough class pumunta ng pharmacy, please, and then asking you for a drug sa cough, you have to check first kung anong klaseng cough ang na-experience niya. Aside sa tatanungin mo siya kung gano'n nakatagal yung kanyang cough, ha, kasi isa kabulan na siya. So, pag ano pa lang, like example, a week or 3 days and kailangan niya ng gamot for cough, you have to ask the patient first whether it's a productive cough or a dry cough. So when you say dry cough, walang walang phlegm. Now, pag walang phlegm kasi, pag dry cough, wait lang. Pag unproductive na cough, that is the time we give antitussives. Okay? When you say antitussive, ang meaning niyan, cough suppressant. Okay? Para maundang ang iyahang ubo. Okay? Para maundang ang iyahang ubo. So, example sa antitussives, we have the dextromethorphan. Sa brand name sa dextromethorphan. Sa brand name ano sa market. And at the same time, the butamirate citrate. Yeah, meron tayong Robitussin DM for the dextromethorphan. What else? Yeah, the Tuceran also. So, yan yung mga antitussive natin. Meaning yan, do not give a patient Robitussin DM. Let's emphasize the DM ha, kasi meron tayong Robitussin na guaifenesin. Let's, do not give the dextromethorphan and the butamirate citrate kapag productive ang cough. Okay? Kasi sinusuppress niyan ang coughing. Paano niya pa malalabas yung plema niya kung sinupress mo na yung ubo niya? Nakuha niyo? So again, bigay niyo lang yan ha kapag dry cough. So tama yan siya. Butamirate citrate is sinicon. The sinicon forte. Okay? Tapos, kapag productive naman ang cough, merong phlegm ha. You may choose between mucolytic and expectorant. So sa mucolytic class, ito yung pampahumok sa plema. Okay, pagkahi kay ang plema, lisod kaayo siya igawas, pwede na to siya ipahumok using mucolytic. So ano ba examples ng mucolytic natin? We have the carbocysteine, and then the ambroxol is also a mucolytic. And yung mucolytic talaga sa kanila, yung talaga, tested and proven na mucolytic talaga siya, napahumok dyan siya og plema. It's the acetylcysteine. Ano ba brand name ng acetylcysteine in the market? It's fluimucil. Okay? Very good. Sige. But take note ha, acetylcysteine is also our drug of choice para sa paracetamol poisoning. Kasi acetylcysteine in the body will lead to the formation or production of glutathione. So, di ba si glutathione is a free radical scavenger in the body. Manglimpyo na siya sa body. Okay? Now, ang expectorant, from the name itself, expectorant, merong phlegm, and if you are going to take this, ma-expel. This will help us expel the phlegm. Si mucolytic kasi pampahumok sa una sa plema ha. Pero pag gusto ka expectorant, pampa-expel talaga yun siya sa phlegm para magawas dyan mo ang phlegm, especially yung phlegm na natapok sa imuhang bronchioles na reason why nahihirapan kang huminga. So, ano ba example ng expectorant? It's guaifenesin. Okay? So, yan na yung example Robitussin. Hindi ko na alam ang ibang brand names nito sa market though. But yan yung example. But sa board exam, may question dyan sa board exam, what is the best expectorant? Ano ba best expectorant natin? Tuob. Si tuob. Best expectorant ha, Solmiox is carbocysteine, so it's a mucolytic. It's not an expectorant. No? Kasi naabot. Naabot naman mo sa honey. Robitussin is just guaifenesin. Ha? The DM is the dextromethorphan. That is just a brand name. So, ang answer dyan, class, best expectorant natin is water vapor. Water vapor. So, in ano, yung tuob, pwede naman, pero anong part doon sa tuob yung best expectorant? It's the water vapor. So if you want to expel the phlegm, magpausok ka. Okay? For the exam question natin yan. It's really water vapor. May asthma si patient. Pag binigyan mo yung patient mo ng salbutamol, pwedeng may asthma. Pwede din naman siya kasi sa ubo class kasi pag example may ubo ka, nahihirapan kang huminga, no? Para to dilate your bronchioles and at the same time to expel the phlegm. By the way, ang pinapartner natin with the salbutamol, which is a bronchodilator, is an expectorant. That is why it's guaifenesin. Para as the bronchioles gets dilated, you can also expel the phlegm na nandoon. Pero hindi natin pinapartner si anti-asthma, si bronchodilator, and ang mucolytic. Okay? Hindi actually advisable ang mucolytic for asthmatic patients. I hope this is clear. Kasi minsan, nag-asthma yung patient, inuubo, tapos binibigyan natin ng mucolytic. Mas mahihirapan siyang huminga class. Kasi sa mucolytic, ipahumok lang magud niya ang phlegm inside, pero hindi niya talaga pinapa-expel. So, ikaw na yung pusa mag-e-expel sa phlegm dyan. Now, pag hindi kasi siya na-expel, nahumok lang siya inside, magtapok man lang gud gihapon siya sa bronchioles, and hindi ka masamot ang patient o dili makaginhawa. So again, pag asthmatic ang patient, do not give them mucolytic. You may give them bronchodilator and then you may partner it with expectorant if merong plema para ma-excrete siya, dili siya mag-deposit dito sa bronchioles. Nothing else? asthma same ba? Included ang asthma dito sa bronchospastic disorders na kasi ang isang symptom sa asthma is bronchospasm. So yung lining of the bronchioles will contract rapidly and nahihirapan yung hangin na dumaan. And yan yung reason bakit merong wheezing na kapag huminga sila, may sound. Kasi nga, medyo hindi efficient yung flow ng hangin inside kasi nagko-contract yung smooth muscle. We call that bronchospasm. So, isa siya dyan sa bronchospastic disorders. Anything else? Wala na? Sige. So if wala na, let's move on to the third group of drugs we use for our asthma. We have our anti-muscarinic agents. So remember anti-muscarinic. Balik kayo doon sa acetylcholine ninyo. Huwag kalimut ha, acetylcholine, dumbbells. B for dumbbells is bronchoconstriction. So, pag merong bronchoconstriction sa acetylcholine, let's antagonize it. That is the reason why we have the anti-muscarinic agents na pwede nating gamitin para sa asthma. Okay? So, one of that is the atropine from our first, ito na observe sa Datura stramonium ha, which is class considered syempre a bronchodilator kasi nga we are reversing the dumbbells, the bronchoconstriction in the dumbbells. So since this is anti-muscarinic, atropine will just bind to the muscarinic receptor and inhibit the action of acetylcholine. So pag walang acetylcholine, walang bronchoconstriction. Okay? So, clinical uses ng ating muscarinic antagonists or we call them anti-muscarinic agents. Syempre, again, they are effective bronchodilators. So, we also use them sa asthma. Pero, most of the time, you don't really see atropine being used for asthma. Instead, yung pinakasikat sa mga anti-muscarinic agents natin is si ipratropium. Okay, si ipratropium bromide. So, I cannot remember the brand name of the ipratropium though. Yung ipratropium lang talaga ha. Kasi most of the time, this is in combination with our beta-2 agonist agents. Okay, agonist agents. Like salbutamol, in a partner siya with ipratropium bromide. So, example, we have the Duavent. Kaya siya tinawag na Duavent kasi dalawa we have salbutamol and at the same time ipratropium. Okay? So pwede lang tayo mag-combine ng drug class ha kapag hindi sila magkapareho ng mechanism of action. Though parehas sila ng effect sa body na they both causes bronchodilation but since they don't have the same mechanism of action, pwede silang i-combine. Kasi kapag the same mechanism of actions ang drugs, anong tawag natin dyan? Duplication. So, wala yan siyang significant activity in the body. Parehas pa rin yung effect nila kasi mag-aagawan lang naman yan sila sa receptor. Whereas, kung hindi sila magkapareho ng effect, talagang efficient like this one yung bronchodilation na mangyayari. Kasi, the example, the salbutamol or albuterol will bind to beta-2 receptor and cause bronchodilation. While si ipratropium naman will bind to the muscarinic receptor and then causes bronchodilation also. So you will have efficient bronchodilation sa iba't ibang receptors in the body. Kasi yung mga organs natin, remember, maraming receptors ang nag-e-exist dyan. So kung nag-dilate siya because of the alpha beta 2 receptor stimulation, magda-dilate siya, but at the same time, magiging mas efficient pa siya kasi pinakialaman mo din yung muscarinic receptor. Okay? High bent? I'm not really sure with the high bent. What is high bent? Is that still a combination drug? High bent? Yeah, pwede rasad ang iprat. Oh yeah, salbutamol lang ang high bent, no? It's not really a combination drug. Ay, yung high bent plus ang combination drug. Salbutamol ang high bent. Tapos high bent plus ang combination drug. Okay. Sige. Pero, pwede magamit og ipratropium. Yeah. You can use ipratropium lang na hindi siya in combination with salbutamol. Pwede naman. Okay. Oxytropium, yap. Pamilya na nila ha, pati ang tiotropium. Parehas yan silang lahat na anti-muscarinic. Like, mas mahal ang Duoben. Ano siya? Wala ko kasabot. Isan. Oh. Sa pharmacy. Okay, sa pharmacy. Unsa ilang ginahimo? Nagahatag sila og combination drug. Duoben. Like, salbutamol plus ipratropium. Oh, wala tayong. Duoben jud ilang ginahatag kahit salbutamol lang ang inaas ni patient. Okay. Depende yun siya sa ano ha, sa walay reseta. Kanang like sa order ng physician. Pag sa reseta talagang salbu plus ipra, you have to follow that na you dispense the combination drug. Pero kung ang nasa order ng physician sa ating patient is salbutamol lang, just give salbutamol. Bakit Duoben ang binibigay? Kasi nakalimot sila. You have to, pag nag-work na kayo sa pharmacy, yan yung i-correct nyo. Kasi like kung salbutamol lang ang hinihingi ni patient, give him or her the combination drug. Basig manggod ang thinking ana nila, kung clerk lang ha, kung dili na siya pharmacist, ang thinking manggod nila, pwede rin siya kasi sa Duoben, nabitaw siya sa salbutamol. Ana siguro lang ang thinking. Pero just follow the physician's order. Ana lang siguro. Tama siguro ako ginaisip na abi nilang okay lang kasi naman gihapon siya sa salbutamol. Pero kung dili jud combination drug ang ginapangita sa patient, just give salbutamol. Salbutamol. Okay lang naman kung nagbigay siya ng Duoben. Pero as much as possible, let us follow the physician's order. Okay? Sige, si tiotropium naman, aside from, it can be given to asthma ha, pero most of the time we use this for COPD patients. So this one is the dose, 18 microgram dose. Kasi meron na yan siyang 24 hours na duration of action. Ansa? Awkward ka ayaw makigbatin na. Kanatong problema, class. Kay student pamanggod mo. So, medyo you cannot assert your stand. Tapos sila kay mga trabahante sila dito. Kung unsa manggod na ang ilahang naanadan o na ilahang ginahimo, actually lisod ka ayaw mag-correct og mga PA. So remember, di ba, nag-work ako sa pharmacy for just 3 months. Meron silang mga ginagawa na hindi talaga siya supposedly dapat gawin. Hirap nilang i-correct. Okay? Tapos yun pa talaga yung tinuturo nila sa mga customers, sa mga patient. But if you will become pharmacist soon, I hope you can instruct your PAs also para we will achieve the maximum activity of the drug. Wait lang, Kylo, just plug in my laptop. Okay? Yeah, pwede. Pero yung dose nila, syempre, hindi magkapareho. Okay? Anything else? Wala na? Okay. So if wala na, let's move on to our corticosteroids class. Okay? So si corticosteroids, they are actually endogenous in our body. Okay? Actually, ano yan sila, no? Galing yan sila sa ACTH hormones natin. Kapag gumigising kasi tayo, nagpipik yan yung ACTH, adrenocortical hormones natin. And yan yung actually nagdi-dictate no ng kung mumata na bata or dili. Pero si corticosteroids kasi maraming actions yan sila sa body ha. Maraming actions. Dosing sa nebule sa adult ug sa pedya. Ansa na siya? Salbutamol lang. Let's check. Nebule, no? Nebule. Ito. Dosing. Adults. 2.5 to 5 milligrams salbutamol up to 4 times a day. Pediatric population, if the children is aged 12 years and above, the same sa adult. Pero if it is 4 to 11 years old, that's naman. Up to 4 times a day. Oh, almost the same lang man. Pero yung sa infant, yung hindi. Medyo, pag infant, may mga study kasi na nagkakos siya ng hypoxia. So, hindi siya ginagamit talaga dapat sa infants. Dapat ha, dapat. Hindi ginagamit. Sana pa? Saan ang dose na wala? Humans, absorption, volume of distribution, metabolism, clearance, toxicity, pathway, interaction. Interaction na siya naman. Dosing. Mali. Tulugan ba? Ay, wait lang. Saan na to? This I did. Sabi kasi siya sa dose. Yeah, up to 4 times a day gid sila no. This one. Adult. Wait. 5 milligrams nebule via nebulizer 4 to 6 hours as necessary. Divided by 6, 4. 4 times a day. 4 times a day yung adult, magpausok. Ang sa bata, mas mababa pala yung dose nila. 2.5 milligrams na nebule yung sa kanila. Pero pwede din namang 4 times a day. Walang, ano dito, wala siyang para sa baby talaga. Ang ilahang, mostly sa mga, sa tawag na, information about salbutamol is magsugod ang age diri 4 hanggang 12 years old. Tapos mas tigulang sa 12 years old, adult dose na sila. Walang pang baby dito. Yun yung nabasa ko last time na nagkukos siya ng hypoxia sa babies. Pero pwede ata siya kung like 2 years old, 3 years old. Pero kung less than 1 year old, ito na ata yung medyo alanganin tayo. It has to be supervised by the doctor in cases na mag-cause siya ng problem sa paghinga. Okay? Sige. Anything else? Wala na? Sige. So, again, sa corticosteroids class, they are normally found in our body, ha? So, ano ito sila? Derivative of the ACTH hormone. Nare-release ito sila sa, I mean, ano ito, not really yung ACTH hormone yan, mahimo siya corticosteroid. No. The ACTH hormone will trigger the release of these corticosteroids in our adrenal glands. Okay? Now, pwede silang gamitin sa asthma. I'll show you the pathway later. Tapos binibigay sila most of the time late in the afternoon. Yung papunta ng sa gabi. Kasi most of the asthma attacks happen at night, diba? Para to prevent that one from happening. And for asthma, syempre, we are going to use the inhaled delivery system for us to avoid yung mga systemic na effects ng corticosteroid kasi marami yon. Maraming adverse activity yung corticosteroids, especially if we take it orally or we inject it parenterally. magkakaroon siya ng activity with the other parts of the body, and most of that is hindi kaaya-aya. So, pag asthma lang ang problema ng patient, please use the aerosol treatment, the inhaled ones. Okay, so take note, corticosteroids are only labeled as controllers and hindi talaga sila cure for asthma. So sa mga asthmatic dyan, pagka nagko-corticosteroid kayo, hindi yan siya treatment sa asthma niyo ha. Ano niyo lang yan siya, parang prevention for prophylaxis, especially at night para dili sigig atake inyong asthma. So what are the examples of corticosteroids na ginagamit for asthma? We have here beclomethasone, budesonide, cyclesonide, linezolide, mometasone, and triamcinolone. So meron ito silang mga delivery systems na inhaled na para sa asthma. Though you may also see them in other dosage forms like creams, ointments. Meron din itong tinitake orally, pero doon na yun sa ibang conditions, especially inflammatory conditions like may allergies ka or whatever. Pero kung sa asthma, again, please use the aerosol treatment. Okay? Kasi kapag tinake mo siya using other dosage forms, you may have the effects in the body na unwanted. So ano ba activity ng corticosteroids? Asa na yun? Let me show you the pathway. I don't know if you have this one in your pharmacology one. Where is my pen? Saan yun? Yan. This is the eicosanoid pathways. How man ba mong eicosanoid sa inyong pharmacology 1? Ay, nga naman eh. Nag-eicosanoid pathway kayo? Wala din ako saksak. Tingnan, di ba siya maagi? Bastos. Okay. Wait lang. Ah, well. Okay. Ay, ayan na. Wait lang, press. Wait lang ha. Moagi. Ba na pen? Yan. Pen. Okay. Okay. Let's talk about the eicosanoid pathway kasi ito yung pathway natin sa inflammation. Kasi 'di ba, inflammation pa rin naman yung asthma. Meron namang activity diyan, especially yung ating mga white blood cells. Papunta yung activity nila sa inflammation, especially in the bronchioles. That is why there is narrowing of the airway. So ano ba mangyayari dito sa pathway natin? So meron tayong, syempre, everything starts with a stimulus or a stimuli. Just like when you inhale allergens, o kaya you have injuries, kung sa kung sa inflammation nga part, syempre injury becomes a stimulus. Okay? So because of this stimulus class, this will lead to the release of the I forgot the name of the lagi. Wait lang. Meron yan siyang nire-release before ang phospholipase A. I forgot. Wait lang ka na sa, sa akong dila. Lang para madali ito. Ayan na siya. Sa mukha. Nagani siya. Okay. Ayan. Because of the stimulus class, yung phospholipid na nasa cell membrane natin, ito ha. Ilagay ko dito. Nasa cell membrane. Magre-release yan siya ng arachidonic acid. Okay? So dito nagsa-start yung inflammatory action natin sa body. So magre-release lang yan siya ng arachidonic acid through the help of the phospholipase. So enzyme ito ha, phospholipase. Pwedeng C, pwedeng A2. Depende kasi yun. Hiwalay na lang natin. Pwede din kasing diacylglycerol here. Pag diacylglycerol, yung phospholipase na responsible is the phospholipase C. S na siya ha, S. C. Ito, phospholipase A2 for our phospholipids. But nevertheless, both components of our cell membrane will lead to the release of arachidonic acid. Okay? Now, itong si arachidonic acid, board exam question, ito class ha. Merong dalawang enzyme na nag-a-act dito. Ang isa, cyclooxygenase, yan yung tinatawag natin na COX. Are you familiar with that? The COX. And then yung isa, we have the lipoxygenase. Ito naman yung tinatawag natin na LOX. Okay? Now, kapag ang nag-act on the arachidonic acid is si COX, si cyclooxygenase, ang nire-release niya na mga eicosanoids, ito yon, si prostaglandin, and then si thromboxane, and si I forget the other hindi na ako isulat ng isa lang dahil wala man kayo siya activity in the inflammation kaya ako siya nakakalimutan. And then si lipoxygenase naman class, ito yung nagre-release ng leukotrienes. At tama lang ito, lipoxygenase. Okay? So ito yung again, nagre-release ng leukotrienes. Now, I don't know if you know something about prostaglandins, pero ito yung responsible class sa inflammation. Kapag na-release na ito, ang next niyan, inflammation na. Okay? Any part of the body na kung saan nandun yung stimulus, example doon ka na injury, but in the case of asthma, it might be the bronchioles. Okay? Si thromboxane naman is more on platelet aggregation, though it is also responsible in some inflammatory action, pero ang kanyang activity is more on platelet aggregation. When you say platelet aggregation, magkumpul-kumpul ang platelets, no? Leading to blood clot. Okay? And we have the leukotrienes. Ang kinukos naman ng leukotrienes is bronchoconstriction. Okay? So yan yung eicosanoid pathway natin sa lipoxygen is nasa inflammatory condition pa rin, but it's more on the prostaglandins kasi. Now, plus, itong pathway na ito can be inhibited by drugs. Kasi nga, ang ending ng pathway na ito is the formation of inflammation, andyan pa yung blood clot, and then at the same time, constriction. So may mga parts dito na pwedeng i-inhibit ng ating mga drugs. So number 1 dyan, dito sa phospholipase. Dito nagtitake ng action si corticosteroids. Okay? So yan yung yan yung activity niya. Mechanism of action ng corticosteroids, inhibit phospholipase enzyme. Kasi pag walang phospholipase, wala na ito lahat. Walang arachidonic acid, wala na yung ibang mga substances in the body that are pro-inflammatory. Yan ngayon yung mag-explain ng anti-inflammatory activity ng corticosteroids. So si corticosteroids class, pwede mo siyang ibigay sa asthmatic patient. Bakit? Kasi inhibit niya ito. So, ang part class ng bronchoconstriction will be inhibited. Okay? And at the same time, inhibit niya din yung part dito sa COX, sa cyclooxygenase. Ayan, para walang inflammation. So, yung mga inflammation sa bronchioles brought to you by the work of the white blood cells will also be inhibited. Okay? And at the same time, syempre, corticosteroids can also be given to inflammatory conditions. Pag meron kang inflammation dyan, whatever it is, kung unsa man ang nag-cause na imuhang inflammation. And at the same time, you can give this to allergy. Kasi take note class, allergies, especially those na nagmamanifest sa skin, are also considered inflammatory conditions. Yung mga rashes mo dyan, pruritus na yan, is an inflammatory condition. So it might also be inhibited by corticosteroids. And at the same time, corticosteroids are considered immunosuppressant. Okay? Because of the suppressant activity of this in the eicosanoid pathway, the activities of the white blood cells will also be suppressed. Okay? Masusuppress din yung white blood cells activity. So marami masyadong pwedeng paggamitan ng corticosteroids. Asthma, inflammatory conditions, allergy, and pwede din siyang immunosuppressant. So like binibigay din siya, for example, during, ano tawag dyan? Yung may mga transplantation, diba? Pag nag-transplant ng isang organ, to prevent the body in rejecting the newly transplanted organ, pwede silang bigyan ng immunosuppressant. So that includes the corticosteroids. Again, to lessen the activity of the white blood cells para hindi i-attack yung bagong organ. Okay? It's already 8:59. We'll continue our discussion this afternoon. Continue ko na lang itong asthma, pero asthma class is included sa lecture. Tapos remaining time natin, I'll start with a new lesson.